This lecture is how to use monitoring data to make wise decisions. And I'm going to talk about the making of wise decisions in clinical medicine based on patient data, with a focus on the data that are displayed on bedside monitors. At the most rudimentary level, a monitor produces waveforms and numbers. But these are of no value unless they help physicians make better decisions when caring for patients. What patients want most from their doctor is a wise decision. In a landmark paper on clinical decision-making, Arthur Elstein pointed out that good clinical judgment is the foremost attribute desired in physicians. Physicians commonly use the terms wisdom and judgment, yet they have great difficulty in explaining what they mean by these words. A wise physician is so discerning in understanding clinical problems that he or she knows how to get the best out of situations despite the challenges involved. So how does a physician become wise? Wisdom certainly requires knowledge, and in the case of monitoring, this means a good understanding of the workings of the machines involved. Without this knowledge, a physician will be enslaved by the machines rather than being their master. In this textbook that I published has over 1,500 pages on monitoring. So the body of knowledge pertaining to intelligent use of monitors is extremely large. Patients realize that a doctor needs a large body of knowledge to make a wise decision. John Fitzgerald Kennedy was often photographed using crutches for back pain, for which he underwent 4 surgical operations. When he was 27, he underwent a laminectomy and discectomy by a neurosurgeon in Boston. And during a prolonged and difficult recuperation, JFK wrote to a girlfriend, in regarding to the fascinating subject of my operation, I will confine myself to saying that I think the doc should have read just one more book before he picked up the saw. In JFK's mind, the unsatisfactory surgical result was the consequence of the surgeon's inadequate knowledge base. Knowledge is gained from deep reading, that's concentration without distraction. Deep reading leads to the formation of rich neural circuits across regions of the brain that govern such cognitive functions as memory and interpretation. Neuroscientists have begun to investigate the difference between reading online and offline. Reading online is accompanied by a dramatic increase in the opportunities for distraction. In Proust and the Squid, the story of science and the reading brain, research psychologist Marianne Wolf asks, will the split-second immediacy of information gained from a search engine and its sheer volume derail the slower, deliberative processes that deepen our understanding of complex concepts? In this BMJ article, I discuss the difference in comprehension of material presented on paper versus online, and that material that's read online is stored in a weaker form of memory than is material that's read on paper. So given the importance of rapid decisions in critical care medicine demanding instant memory recall, a trainee is best advised to acquire the foundation for his or her storehouse of knowledge from a textbook rather than from online resources. But as the 18th century poet William Cowper intoned, knowledge and wisdom, far from being one, have ofttimes no connection. Knowledge dwells in heads replete with thoughts of other men, wisdom in minds attentive to their own. Cowper recognizes that wisdom is not simply external knowledge, but is based on a person's own method of thinking. So how do doctors think? This is the subject of two recent books by Groupman and Montgomery, as shown here. These contain useful information, but deeper insight is contained in a recent book by the Nobel laureate Daniel Kahneman entitled Thinking Fast and Slow, which brings together 5 decades of research on human decision-making. Kahneman presents human thinking as involving two independent systems. System 1 is amazingly fast, intuitive, and effort-free. System 2 does the slow work of forming judgments based on conscious thinking and deductive reasoning. System 1 operates automatically and quickly with little or no effort and no sense of voluntary control. When System 1 runs into difficulties such as answering the multiplication problem 17 by 23, it calls for help from System 2. System 2 is essential for tasks that involve comparison, choice, and ordered reasoning. We view it as being coldly logical and analytical. Its operations are associated with a surge of conscious attention. Doctors like to believe that they mostly employ System 2, but all humans use error-prone System 1 for most activities. Given that physicians carry the responsibility for whether a patient lives or dies, they persuade themselves and they persuade their patients out of fear of lawsuits that their decisions are analytical and rule-based. The failure of physicians to recognize the intuitive factors in decision-making hampers self-education and systematic learning. A good description of System 1 is that it rapidly jumps to conclusions, making it particularly susceptible to cognitive illusions. One Kahneman paper cited by the Nobel Committee was his report that over-reliance on seat-of-the-pants decisions, characteristic of System 1, can lead to large systematic errors which have serious and persistent consequences. A manifestation of such a cognitive illusion in the ICU is the delay in commencing ventilator weaning. The first 2 randomized trials on weaning techniques revealed that 60 to 80% of patients ventilated for a week or more had the ventilator successfully removed on the first day they were evaluated for weaning. Many could have had the ventilator removed a day or several days earlier. That is, clinicians employing System 1 judged these patients not to be ready for a T-tube trial. To overcome cognitive illusions that originate in System 1, Kahneman recommends that you recognize the signs that you're in a cognitive minefield, slow down, and ask for reinforcement from System 2. In the case of weaning, clinicians need to recognize that System 1 judgment that a patient is not ready for a T-tube trial is likely to be wrong, based on the RCTs of Burchard and Esteban. Aware of this cognitive minefield, clinicians should get help from System 2 and explicitly perform screening tests, weaning predictors, to check for a patient's readiness. In this instance, we see the need to combine thinking with precise knowledge. The clinician needs to know the reported performance characteristics of the diagnostic test being used. Frequency to tidal volume ratio has a sensitivity or true positive rate of over 0.9 and a specificity of 0.67. As such, FOVT should be used primarily to screen for weaning readiness. By alerting an unsuspecting physician as to a patient's readiness hours or days before the clinician would otherwise order a weaning trial, System 2 and weaning predictor tests can circumvent the cognitive errors to which we are all prone. While System 1 is the source of much that we do wrong, it is also the origin of most of what we do right. Clever use of System 1 is closely connected to the development of expertise. And I define expertise as sound clinical judgments that result in wise decisions and actions based on clinical data. There is a positive feedback loop between System 1 and expertise. The acquisition of expertise results in a better developed System 1, and sophisticated use of System 1 is what distinguishes an expert from a non-expert. So how does a trainee develop expertise? The deepest insights on this subject come from the work of the Dreyfus brothers. In a careful study of how a trainee turns into an expert over time, the Dreyfus brothers show that a person passes through 5 stages of skill acquisition. The novice acquires a skill by learning context-free rules. Novices assess their own performance by how well they follow the learned rules. But like the training wheels on a child's first bicycle, these first rules must be put aside in order to proceed. The advanced beginner gains practical experience by recognizing meaningful elements in concrete situations, such as recognizing bronchial breathing in a patient with pneumonia. Experience is immeasurably more important than any verbal description. The competent nurse no longer goes from patient to patient in a prescribed order, but assesses the urgency of a patient's needs. A proficient practitioner spots certain features that stand out as salient and others that recede into the background and are ignored. The final stage is the expert, who typically knows what to do based on mature and practiced understanding. Experts are generally not aware of solving problems and making conscious, deliberative decisions. Rather, they do what normally works. The intuition of experts, clinical judgment, and tacit knowledge are illustrated by the following vignette. A nurse sees a patient fighting the ventilator and calls a resident to evaluate. The resident evaluates the patient, finds no obvious reason for distress, and plans to administer lorazepam. The intensivist looks at the airway pressure form and notes a curious bump at end inspiration, causing her to immediately suspect activation of the expiratory muscles during mechanical inflation. During pressure support, the switch between inhalation or inflation and exhalation is delayed in patients with COPD because they have a prolonged time constant. The delay fosters activation of the expiratory muscles while the ventilator is still trying to push gas into the patient. On switching the ventilator mode from pressure control to assist control, the patient stops fighting the ventilator. The bump at end inspiration activated information stored in the expert's memory, causing a particular diagnosis, expiratory muscle activation, to spring to mind. Experts are not so much thinking as reacting. Over many years, experts build up a bank of experiences stored in their memory that shapes how they perceive new information. In most cases, the skill is not the result of conscious reasoning, but of pattern recognition. It's a feat of perception and memory, not of analysis. Experts use their memories to see the world differently. They notice things that non-experts do not see. Experts process information flowing through their senses in more sophisticated ways. Complex strategies based on System 2 frequently produce inferior results to quick intuition. We teach medical students, and we should, to search for all relevant information, weigh it, and formulate a differential diagnosis. The German psychologist Gerd Gigerenzer points to numerous psychological studies in which show that experts commonly base intuitive judgments on a single good reason. In this study, a heuristic called take the best or one reason decision making was a more accurate predictor than a more complex strategy. The following is a clinical study where over-reliance on System 2 resulted in inferior patient care. Tanius undertook an RCT to determine whether the inclusion of F over VT in a weaning protocol influenced weaning time. If in the F over VT protocol group, patients could proceed to a weaning trial if, and only if, they had an F over VT of less than 106. The duration of weaning was longer in the protocol group than in the non-protocol group. System 2 was rigorously employed. Patients who had an F over VT of 105 or less progressed to a weaning trial, whereas patients who had an F over VT of 106 or higher were returned to the ventilator. But it's totally daft to decide an entire day of ventilator management on a 1 unit difference in a single measurement of F over VT. Instead, clinical decisions need to be customized to the particularities of each individual patient. This study illustrates how rigorous employment of System 2 produces inferior patient care. With regards to judgment, which I define as the ability to combine hard data, questionable data, and intuitive guesses to arrive at a conclusion that events prove to be correct, the novice and advanced beginner exercise no judgment. The competent practitioner judges by means of conscious deliberation. The proficient or expert makes judgments based on their prior concrete experiences in a manner that defies explanation. If you ask experts for the rules they use to reach a clinical judgment, you force them to regress to the level of a beginner, and they state the rules they still remember, but they no longer use, such as the use of a long laundry list approach to differential diagnosis. The hallmark of an expert is sound intuitive judgment. Gigerenzer defines intuition as a judgment that appears quickly in consciousness, whose underlying reasons we are not fully aware of, and is strong enough to act upon. Intuition shares many features with tacit knowledge, which is contrasted with explicit conscious knowledge. Tacit knowledge involves inarticulate knowledge based in actions involving the fluid performance of a bodily skill rather than conscious deliberations. Conscious thinking about the sequence of actions interferes with execution and is detrimental to performance. Here's an example of clinical decision-making based on tacit knowledge and nothing else. When deciding to wean or extubate a patient at risk of upper airway obstruction, System 1 intuition is unreliable. Conversely, the decision to intubate a patient is almost completely made by System 1. There are no set of numbers or rules that a clinician can rely on. The main indication for intubation is that a clinician decides by intuition that a patient has tired out to the extent that she needs to be placed on the ventilator. And that is why medical students who rely on context-free rules find it very confusing to understand why one patient is intubated and another patient is not. The person who introduced the term tacit knowledge, Michael Polanyi, was a Hungarian physician who spent most of his life working on physical chemistry before switching to philosophy of science. Polanyi's central thesis of epistemology was, we can know more than we can tell, and we can tell nothing without relying on our awareness of things we may not be able to tell. In ventilated patients, John Marini taught us that by using an end expiratory occlusion, we could quantify the magnitude of hyperinflation in terms of auto-PEEP. About 150 years beforehand, the Dublin physician William Stokes wrote a masterly description of dynamic hyperinflation simply based on physical examination alone. He wrote, "I shall describe another sign which promises to be of the greatest importance in diagnosis. It is founded on the difficulty of expiration, attributed to diminished elasticity of the lung. It then struck me by making the patient perform a number of forced inspirations rapidly, the lung might be so far distended with air as ultimately to nearly prevent its further expansion. Everything we know about auto-PEEP is here. The focus on expiration, the diminished elasticity of the lung, the rapid respiratory rate, and the hyperexpansion. The skill that Stokes exemplifies, that of outstanding physical examination, is what Michael Polanyi calls connoisseurship. These skills can be communicated only by example, not by precept. You cannot learn these skills out of books or in a lecture hall. Much of the art of knowing which a student or resident needs to learn cannot be formulated as written precepts. Instead, these skills are learned during years of apprenticeship under the guidance of a master. But if a skill is not employed repeatedly, it'll be lost. I doubt that any physician today is able to perform chest examination with the same level of skill as William Stokes. Otherwise, why did it take 150 years to rediscover auto-PEEP? That level of skill has disappeared, just as the connoisseurship in constructing violins at the level of Stradivarius. The Nobel laureate Herbert Simon did extensive research in connoisseurship and the perception of experts by studying what might seem to be the least intuitive of fields, chess. To develop the intuitive skill of a chess master required at least 10,000 hours of dedicated practice. That means playing chess 5 hours a day for 6 years. From hours of intense concentration, a chess master becomes familiar with thousands of configurations and sees the pieces on the board differently from the rest of us. From his research, Simon concluded that intuition is a form of pattern recognition. He writes, "The situation has provided a cue. This cue has given the expert access to information stored in memory, and the information provides the answer. Intuition is nothing more and nothing less than recognition." Simon's strong statement reduces the apparent magic of intuition to the everyday phenomenon of memory. Memory holds the vast repertoire of skills we acquire over a lifetime of practice. This connects back to the point I made earlier about the importance of deep reading on the printed page for trainees when laying the foundations for their storehouse of knowledge, as opposed to scanning online resources. It is memory which enables wise decisions and skilled performance, involving the ability to deal with vast amounts of information swiftly and efficiently. In a book highly recommended by Kahneman, Ford claims, a great memory is not just a byproduct of expertise, it is the essence of expertise. Talk of intuition has obvious appeal to the lazy who think that true expertise is nothing more than a random guess or the inspiration of a Zen Buddhist or Jungian mystic. Guessing involves reaching a conclusion when one does not have sufficient knowledge or experience to do so. In contrast, true intuitive skill is the final fruit of many years of experience and the use of deliberative analytic thinking as a trainee. Even though it looks automatic and we call it intuition, it is knowledge hard-earned and shaped by years of experience. Popular lore tells us that genius is born, not made. On the contrary, extensive research by Anders Ericsson, who trained with Herbert Simon and is now the world's foremost expert on experts, shows that true expertise is the product of years of intense practice. Experts in any field are always made, not born. To know when to trust intuitive judgment of System 1, Kahneman suggests that you ask two questions. First, is the environment in which the judgment is made sufficiently regular to enable predictions from available evidence? Kahneman says the answer is yes for many areas of clinical medicine and no for pickers of stocks on the market. Second, do the professionals have an adequate opportunity to learn the cues and the regularities? The answer depends on the professional experience and the quality and speed with which they discover their mistakes. Anesthesiologists are well placed because the effects of their actions are usually quickly evident. In contrast, Kahneman notes that radiologists obtain little information about the accuracy of the diagnosis they make and the pathologies they miss, and are less likely to develop through intuitive expertise. As I mentioned, overconfidence in System 1 intuition can be disastrous in certain situations, and clinicians need to call on the explicit resources of System 2. To make wise decisions from monitored data, clinicians need to integrate System 2 analytical reasoning into their intuitive practices. When properly applied, rational deliberation sharpens intuition. Unfortunately, there are no fail-safe rules that dictate when to switch from System 1 to System 2. Kahneman confesses that he is still susceptible to the errors of System 1 intuitive thinking, including overconfidence, extreme predictions, and so on. He writes, "I have improved only in my ability to recognize situations in which errors are likely, but that at least is half the battle." So in summary, making wise decisions from monitored data requires extensive background knowledge of physiological principles, years of hand-on experience gained from taking care of thousands of patients, awareness of the power of System 1 intuition, recognition of when to ignore intuition and call on the calculative rationality of System 2, mental agility to anticipate the consequences of a particular decision. So in conclusion, the tripartite of knowledge, experience, and foresight is the ultimate desideratum, together with a dash of luck. Thank you.